Dear viewers, welcome you all to our show Orthopaedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. And definitely by getting vaccine if we have the facilities like us, Bangladeshi people. And we would like to thank our Honorable Prime Minister Sheikh Hasina for giving us this scope to get the vaccine as early as possible. Dear viewers, today our topic is the magic of Ilizarov, and the part is Ilizarov in forearm and hand, the safe zone, corticotomy, and wire fixation in case of forearm and hand. And our honorable speaker is Professor Mofakharul Bari sir, a legendary Ilizarov surgeon in Bangladesh. I would like to request Professor Mofakharul Bari sir to join with us. So welcome to our show, Orthopedic Solution Academy.
Good afternoon. Thank you, Tanveer, for your good introduction.
Thank you very much,
sir. My dear friends, can I start? I can start now.
Just a minute, sir. I would like to request our honorable academic expert from Kurgan, Russia, a very learned and scientist of Ilizarov, Professor Novikov sir from the Russian Institute of Ilizarov. Professor Novikov sir from Russian Institute of Ilizarov. Sir, welcome to our show.
Good afternoon, all of colleagues. Good afternoon.
Good afternoon, sir. Dear viewers, we all face problems in case of a forearm and hand, but how could we overcome these problems and these challenges? Definitely by using the Ilizarov. So our speaker, Professor Mofakharul Bari sir, will show you how we can fix the wear, we can do corticotomy, and where is the safe zone in case of forearm and hand. So I don't want to waste any more time, and I would like to request Professor Mofakharul Bari sir to start his magnificent presentation regarding Ilizarov in forearm and hand. Professor Mofakharul Bari sir, please.
Okay, thank you. Start. Now I would like to start.
Dear viewers, we're waiting for the presentation. I think due to some connection disorder, we just miss our Professor Mofakharul Bari sir. Hope he will connect with us within a few seconds.
Now, can you hear me? And can you see my slides?
Yes, sir. We can see you properly and we can hear you loudly. And that is the excellent slide.
Thank you so much. So, dear friends, I would like to congratulate Tanveer and the Raj TV for giving me the opportunity to talk on Ilizarov, especially in forearm bones and the hands. And so I always love to show this picture. You know, this is a very fantastic Ilizarov center, which is called the Orthopaedic Capital, Orthopaedic Mecca. And this is, I love to show this also, where I worked more than 10 years here. This is the National Institute of Orthopedics and Traumatology in Dhaka. And this is now I working in 2 places of here. This is also the biggest diabetic center in the Asia. You can see here. And this is my private center. These are the Ilizarov center. This is the Professor Ilizarov. You see the 4M, man, meat, method, and magician, an orthopedic inspiration who has the magical thing about the nature. And this is the radius and ulna. Look, just before going to start the Ilizarov, you must keep it in your mind, the radius and ulna, the design of the radius and design of the ulna, hand, and the lower of the humerus. Safe corridors, as I always tell, as a longitudinal regions through which wires or pins can be inserted safely for they can contain neither musculotendinous nor important neurovascular structures. These are easily identified in eccentric bones as regions where the bone can be palpated subcutaneously. If you look at this special device for application of Ilizarov in the forearm, you can see the how in the operation theater we can place the forearm and we can put the wires. So let us see some anatomy. Before going to start the Ilizarov surgery, you must know all these anatomical structures of the radius and ulna and the muscles. And regarding putting the Ilizarov wire, you must know the neurovascular structures of the forearm. Look at these here, median nerve, ulnar nerve, and ulnar artery. This is very important, dear friends. If you don't know these structures, here you can see the how radial artery is passing from here to here. This is the brachial artery, very important. You can see the elbow joint here, and this is the ulnar artery. And except for the posterior interosseous nerve, all previously mentioned structures run in the flexor compartment. This is the flexor compartment. Now, next, you can see the forearm anatomy is complex due to the presence of three major neovascular bundles. What are these? Radial nerve with its two branches, posterior interosseous nerve and superficial radial nerve, and of course the brachial artery you can see, and the radial artery. Now you can see this is your radius, this is your radius, this is your ulna, and you can see how the vessels are passing. So before inserting the wires, you must think about all the superficial and deep vessels. And this is very important. Structure in the forearm. You can see posterior interosseous nerve and supinator muscle here. You can see the course of the supinator muscles and how this nerve, posterior interosseous nerve, passing just above the radial neck and head. Here you can see, and this is coming down in this way. So if you think about the same zones of the proximal radius, the radial nerve is vulnerable in this situation, in this region. The supinator muscles here, supinator muscles blocks the dorsal aspect of the upper third of the radius with the posterior interosseous nerve running through its substance. A skin incision is made, and by a forceps, the space is widened. You can widen the space here, here, and in this way, we can reach up to the bone. Here, just you make a step incision, and you can go to the bone here. This is the ulna, and this is the radius. So, if you think about the distal radius, you shall have to beware of the superficial radial nerve. Look at this, the superficial radial nerve here, and at the same time, the muscles are passing from proximal to distal part. You must keep it in mind the brachioradialis muscle, extensor carpi radialis longus, brevis, and of course the digiti minimi here, and extensor pollicis brevis muscle, extensor pollicis longus muscles, and abductor pollicis longus muscles. Only you must keep it in mind the course of the superficial radial nerve in the distal radius. And if you think about the proximal ulna, in the ulnar pronation, if your ulna is pronated, then you should have to think about the anconeus muscle. The ulnar pin insertion are along the whole shape between the extensor carpi radialis, and the flexor carpi ulnaris. So this is ulna in pronation position. And in the last my lecture regarding the humerus, I showed you the wire stoppers, olive, or you can make like this, A, B, and C, three different varieties. And if you think about the cart of the forearm, we divide into 7 carts. Cart number 1 in the proximal of the radius and head. Just look at these, cart 2, cart 3, cart 4, cart 5, and cart 6, and last one is the hand. Cart 6 is very important. 5 also important. 4 also important. Why important? Because while you are passing, you will pass the wire. You should have to know the vascular structures and the muscles. Now let us see. In the right side, you can see the bones of the forearm bone. You see, I have shown you at the level of the proximal metaphysis. Proximal metaphysis. This is the level of the upper third. This is in the middle third, just in between the proximal and distal. This is in the level of the lower third, and this is at the region of the metaphysis of the forearm bones. Whenever you'll see the fractures in this region. That means space fracture, Colles fracture, molar bottom fracture. In this area, you'll get. And this is the metacarpal bone at the level of the wrist. Two rows, eight carpal bones, and this is the metacarpal bone region, the cut number 7. Now, if you think about this, all this cut, look at this radius and ulna, radius and ulna. These are the muscles, radius and ulna. This is cut one, this is anterior, this is posterior, and always you should have to keep in your mind when you are passing the wires in the proximal part, that is at the level of the cut one. Now look at this direction. One day you cannot learn all these things. This is not so difficult, dear friends. You can see in the A group, this is here. Here, this is the throw the radius and ulna, how you can pass the wire. This is the wire, smooth wire or rolling wire you can pass. And if you look at this B, just throw the radius, only the radius. You're not passing through the ulna. This is ulna, this is radius. And now this is the through the ulna. You can see here the angle between this 5 to 10, here 20 to 25, and first one, the A, 50 to 55, you can make the angle between these in the A group. Now, if you look at this cut 2, again radius and ulna. Look at this. This is the radius. This is the radius. This is the ulna. This is your neurovascular structures. Now let us see the cut 2, how you can put the wires. If you see the group A, this A group, you can see the radius and ulna passing the wires, and you are making the angle 15 to 20. Here you are making the angle 15 to 25, and last one only through the ulna, you are making the angle 10 to 15. Before passing the wires, always you should have to think about the muscles. See, you are not damaging anything here. And same also here, you are not damaging anything. Whenever you are making this angle here like this, between 15 to 25, we are 10 to 15 degree. And in the cut 3, that is middle of the radius and ulna, this is radius and this is ulna. You can see these are all muscles. This is neurovascular structures. If you think about the passing of the wires, look, the radius and ulna is highly vascularized. All the structures here, but before passing the wire, you should have to think about how much angle you are going to do in case of middle of the radius and ulna. And now cut 4. Cut 4 you can see again radius and ulna. Now you can see the cut 4, how you are making the angle here. Look at this again. Look at this. This is in this direction. This is going radius and ulna. That is, you are touching both the bones, radius and ulna. Here you are passing through only the ulna, and then this is through the radius, now the ulna. Then you can make the angle. See here how you are making the angles. So these are the cut 4 and cut 5. Look at this. Same radius and ulna, structures, muscles. You should think about all these things. Now, at the level of the cut 5, you are making the angle. Here you can see how you are making the angle. Look at this, radius and ulna, both bones. Here only through the radius. You are making a wide angle, not touching any vessels, and radius through the ulna, last one. You are not touching the radius. So this is at the level of the 5. And now at the level of the 6, we are getting, I told you earlier, space fracture, Colles fracture, molar bottom fracture, or community any fracture, including the intra-articular. You should think about the cut 6. And this is the level of the wrist. See all the carpal bones, navicular bone, fusiform bone, and capitate bone, radial artery. Only this is the radial artery. And when you are passing your wires, you have to think about the radial artery. This H is median nerve and triquetral bone. This is the K4 and ulnar artery, vein and nerve. That is CH. This is ulnar artery, vein and nerve. So these are all the structures. And regarding the hand, look at this picture. The hand metacarpal bones. Very easy. All the interossei muscles are here, interossei muscles, and dear friends, the metacarpal shafts, second to fifth, and distal section, dorsal view. This is the proximal phalanx of first digit. Now let us see the at the level of the hand, of the metacarpal bones. These are the all sequential stages, the bones and the vessels uh, before going to putting the wires. You should have to think, and there is no too much dangerous area here. The safe corridor, if you think about the metacarpal bones, you'll find it very easily. Now, regarding corticotomy, all the time telling when you are doing corticotomy in the radius and ulna, you should have to preserve the endosteum, periosteum, and the bone marrow. And this is anatomical factors, biomechanical factors, physiological factors. In every case, femur, tibia, and the humerus, radius ulna, you should have to think about all these factors. Common mistakes that I told you all the time before doing for corticotomy: too large skin incision you don't need, poor choice of corticotomy level, uses of oversized osteotome. You should have to very gentle and meticulous when you are doing corticotomy, and direct cutting you should not do that. As a result, you are damaging the bone marrow canal. Injury to nearby vessels, you should have to think that one, and twisting of the corticotomy maneuver before complete cutting of medial and lateral cortex. And sometimes you'll see that you are not doing complete corticotomy. Sometimes you are getting incomplete corticotomy and traumatic, that means destructive corticotomy. Preoperative planning, we must assess thoroughly and examine the causes of the failure. Associated problems like deformity you can get in the radius and ulna, you can get shortening both bones or one bone, or joint stiffness. You should have to think about that. All these patients were explained about problem. The problem before doing surgery, you must explain everything to your patient or patient's relatives. And post-operative management rehabilitation is very important whenever you're doing any Ilizarov surgery. Elbow exercises were encouraged just day after the pain permitted, cleaning the wire sides at regular interval, and discharge the follow-up every week until residual signs of union. And apparatus removed with outdoor or indoor basis, you can remove the Ilizarov apparatus. So, dear friends, this is the view. You can see how you can easily put a hand of a very tiny baby. You can see this is a deformity of the hand. The patient was suffering with AMC, and you are correcting. Just see how to put the wires in the thumb to make the bone straight. So this is the olive 1.5 putting through the metacarpals. These are the safe corridor. And at the same time, when you are putting the wires, you must give pause so that you are not making any thermal necrosis. And all the time, you should have to cool down with saline water or spirit so that you prevent thermal necrosis of the bones and soft tissues. And this is the way how you can put the wires in the metacarpal carpal bones. This is, you see, the direction of the wire in the one finger. Next, we can see, you can see the, look at this. This is the ulnar claw hand, and baby passing through the words, and these are the correction of the deformities of the hand. You can see in the right side, and at the same time you can see in the left side also. So sometimes you need to go for a hammering whenever you're passing one cortex and second cortex, then you can go for hammering gently so that you cannot injure the vessels. Now I would like to share my some cases. Look at this, 17 years old girl, forearm bone, wrist and hand, proximal ulna is present. You see only proximal ulna is present, very big gap. The rest of the ulna is absent. Do you have any other options? See what I have done during treatment. This is radiograph the right elbow and forearm after the application of the Ilizarov. Look at this. Now the bending of the elbow, you can see one bone. So patient was suffering for a long time. After that, patient is okay. So this is the non-union of the right ulna. See, non-union. You can, other options you can do, opening, nothing. So what we have done, put the Ilizarov, and you see the application of the Ilizarov in the ulna and radius. And this is the final follow-up, only 4 months. Union is achieved, and this is the clinical appearance of the patient. Look at this, 40 years old female, DCP failure, atropic gap non-union, lot of holes in the ulna and the radius, vascularity is absent. So what to do? See, radiographic view during treatment with Ilizarov in the left forearm. Now after 2 months, you can see the follow-up. Now from left to right side, you can see the achievement of the union. Bone quality is good. Patient is happy. You can compare this one before, after, final follow-up, after removal of the Ilizarov apparatus. So this is this 15 years old girl, not boy, sorry, chronic osteomyelitis, right upper humerus with pathological fracture. This is another thing. You see atrophy of the both radius and ulna. And this is during the treatment. We have made the destruction fast to 2 rings. And then we have revised the case. And this is the follow-up. And we have put the guide wire to maintain the axis. And see, this is after and this is before. This is after, this is before. Okay? Now, so clinical appearance of the patient after 9 months and hand function. This was published in Kurgan Ilizarov Center, Management of Forearm Gap by Ilizarov Technique. This is also another publication with big gap non-union by Orthopaedics and Rheumatology from American Journal Juniper. And see, the 70 years old female patient, post-infective left forearm wrist deformity. Look at the right side, dear friend. This is the ulna. This is the radius, distal one, and this is the ulna. Now look at the hand. And before surgery, look at the hand, and you just compare the right one with the left one. And what we have done, we have done the osteotomy and lengthened the ulna. You can see here, this is with olive, and one ring here, one ring here. This is with the hinges, and this is the final follow-up. You can see here, the ulna is here, radius is already deformed, is corrected, deformed radius is corrected, and this is okay. Now you can compare the before treatment after 1 year follow-up. Patient is happy, patient parents is happy. So this is a 14 years old girl, right forearm due to the osteomyelitis, radial club hand. Look at this. Do you have any other options? See, this is ulna. You don't see any radius here, segmented radius. Look at this. And if Ilizarov in your hand, if you know the technique very well, then you can see I have done the osteotomy of the ulna for correct the deformity. And here in the wrist joint, what I have done the arthrodesis of these. Now you can see before, during treatment, and now see the external view of the forearm, the radius. Before surgery, you can see the condition of the patient, and this is final follow-up. She can reach her hand to the mouth and take her food. So, dear friend, another very interesting case, comminuted infected case that was treated elsewhere, came to me after a long time with big gap non-union of the ulna and non-union of the radius. And this is the situation. In that situation, you can put the ulna. Now see, I have put a guide wire. I have done the lengthening of the ulna. This is the lengthening process going on. 7 months follow-up. This is 9 months follow-up. 8 months follow-up. This is after 8 months. You can see good callus formation. There is no gap here now. Now you can see the gap of the ulna fully covered, and this non-union of the radius is also healed. After treatment, it took 1 year, only 1 year for this very difficult case. So these are the difficult cases. This is open fracture, Castilo 2. You can go for plating. Whenever you can do plating, you may invite infection. So we have put the Ilizarov, 2 rings you can see with the post, and after you can see the removal of the apparatus, clinical appearance of the patient. This is patient with open fracture. Again, you can see here, and I am doing exercise with the patient. You can do this. I advise all the time patient doing radius ulna, forearm bone fracture or non-union. You can advise your patient to do exercise, the dumbbell, or you can take a panja. See what I'm doing. I'm just calculating the strength of the forearm muscles of the bones of the Ilizarov. Now you can see the right side, and this is final follow-up only after 5 months. This is, you can see diaphyseal eclasis, shortening of the, this is radius ulna bend. He was a medical student, now he's a doctor. I have done the osteotomy here of the radius to correct the bowing deformity and lengthening of the ulna. See, doing exercises. Now he's a doctor. When I did this, he was the medical student of 4th year, and this is his, you see, pronation, supination, and after treatment and clinical appearance of the patient after 1 year. These are the published in American Journal. CVIC, very difficult, deform left wrist and hand. So you can put a ring with the hinges, and this is the correction of the after 4 months only. See again VIC, deformity of the wrist and the elbow. You can see short hand, short radius and ulna, and you have corrected the deformity, and this is the view of the, you can see before surgery and after surgery only 11 months follow-up. These are the all complicated cases. So you can do any kind of deformity in radius and ulna by Ilizarov surgery, by ring apparatus. You can correct everything. And this is, you see volar button fracture, volar button, this is intraarticular, and you can correct all these things. So during treatment, put 1 olive from their side, and you have corrected the deformity, and this is the different moments after treatment. The patient is happy, bone is healed. Look at this comminuted intraarticular fracture, distal radius, very difficult. You can go for open surgery, but there is a bag of bones here. See, only 2 rings in the distal part and a half ring, and you go for distraction, and you can correct the deformity and other fractures by applying the olive wires. So this is before. You can see radiographic view. This is correction of the 3 months. Look at this. Another case, shaft of feet metacarpal fracture. Very simple. You can put plaster, but for accuracy, you can apply the mini Ilizarov in the hand. See here, friend. This is called mini Ilizarov. See, very simple. Mini Ilizarov, 100% accuracy. The patient is happy with Ilizarov in situ. This, at the same time, you could write when you are putting the Ilizarov in the hand. See, look, this is the treatment after 1 month follow-up. This is called mini Ilizarov. This is after 2 months, full correction, machinery injury with loss of bones, and we have corrected everything by Ilizarov. See, patient can write after the treatment. 18 years old boy, and metacarpal lengthening was done here, and macrodactyly. See the middle finger, macrodactyly. I have taken the help of plastic surgeon, and I have shortened this one, middle one, and put the Ilizarov. You can see during treatment, fixed it in the left hand, and this is before, and this is after by application. Now you see the external view and design of the thumb. This is another case, post-traumatic shortening of the proximal phalanx. Look at this. Look at this. This is left side, this is right side. And this is shortening here. Now you can lengthen this one with mini Ilizarov fixator. In this way, this is the good callus formation here. And you have lengthened radiographic view of osteotomized and lengthening part of the proximal phalanx with ongoing callus formation. Here you can see. This is published in Chinese journal and Chinese book. I have a chapter there in China, in Beijing, and they have taken this one and they published in their book, Professor Kinsey's book, and this is before, this after. You can see these are all mini Ilizarov fixator. This is also published in American journal, and in the treatment of acquired and congenital shorting with the hand bones using mini fixator. Here you can see, dear friends, the patients are doing exercises with the, and at the same time, these are the patients are doing exercise Ilizarov fixated in forearm bones. Left side, this is Montegia fracture dislocation. So far I remember, this is deformity. This is with the ulnar non-union, and this is not running.
For Professor Mofakurul Bari sir. Uh, it's because of that was a magnificent presentation for forearm and hand, and we can face lots of challenges by Ilizarov and overcome those challenges by using Ilizarov. I would like to request Professor Novikov sir to say something during this time period regarding the Ilizarov in forearm. Sir, please share your experience with us regarding the Ilizarov in forearm.
very difficult segment for surgery, for treatment, and for any doctor. I recommend start and finished patient with any problem with forearm with experienced doctor, because not only difficult to do surgery in operation theater, difficult to do everything, lengthening, correction, and if some difficulties will come, experienced doctor will help you and show the way how we can go out of any problem. And usually when doctors start to use Ilizarov methods, Ilizarov frame, we recommend start from tibia. Then step by step we go up, start touch femur, then start humerus, forearm and hand. This is last segment, and when you feel are you ready for very high level of using of Ilizarov methods, yeah, you can to do this surgery. Dr. Muhammad, you heard me?
Yes, sir. Yes, sir. We can hear you properly, sir. Can you tell us the proper site of corticotomy in case of forearm, where we can do the corticotomy in case of ulna and in case of radius?
When we start thinking about osteotomy, this is depend for what you need. If this is the deformity, yeah, we need to do surgery, to do corticotomy on the apex of deformity. If we want to do lengthening, better when we will do corticotomy proximal part of ulna and distal part of radius, because this is depend of muscles and depend of
because of our academic expertise from a long distance, that is from Kurgan, Russia, so that we can face some network problem there. As our honorable speaker discussed about the forearm and hand, and our academic expert panel told us about the forearm and hand, that we have to start from the tibia, then femur, then we should go for the forearm and the hand, as because of the forearm and hand is a little bit difficult and complicated things. So don't try it first. First do the tibia, then femur, and then the forearm and the hand. Sir, you are telling about the corticotomy level of radius and ulna. Would you please complete your speech regarding the corticotomy of tibia, corticotomy of radius and ulna? Can you hear me, sir?
Yeah, if we talk about lengthening, usually we do corticotomy ulna proximal part, radius between middle and distal part. This is for lengthening. If we talk about deformity, we did our corticotomy on the apex of deformity for correction. And if we have shortening both of bone, usually we did corticotomy not same level. We make corticotomy different level because during the consolidation, bone help to another bone. Ulna support for radius, radius support for ulna. And when we start lengthening, we never did more than 4 or 5 centimeters last year. Before we finished our plan with 6, 8 centimeters. Few patients we have near the 10, but this is wrong way. This is my opinions, because after this amount, patient many months spent for consolidation. When we start talking about lengthening, we finished with radiological picture. Everything is good, next step. Everything is good, next step. And usually we get excellent result between 3 and 5. Normally 4 centimeters for lengthening, possible more, but after that will come in very big long period of fixation. I am not prefer that. For me, better twice finished with short lengthening very quickly with excellent functional result than once and then 1.5 years spent for fixation. I am just now treat like that. We can finish with 5 centimeters, but better 3 and 2. More quickly and more easy.
Thank you very much, sir. We have our Professor Wafakrul
Dr. Bari, we wait you.
So almost I was in a finishing. There was a phone call from Moscow, and that was disturbing me. Okay?
So we are talking about lengthening of radius and ulna. So would you please add something about the corticotomy level of the radius and ulna and the lengthening of the radius and ulna?
You can, ideally all lengthening you can do in the metaphyseal region. Even I have seen you can do in the diaphysis also, in the radius and ulna. You can do individually radius lengthening, individually ulnar lengthening, or both bone lengthening you can do. Depending upon your case, you can do lengthening ulnar. And I have shown you one diaphyseal classes you have seen, medical student. Have you seen that one? With ulnar shortening, diaphyseal classes, with the deformity of the radius. I have corrected the deformity and at the same time lengthening the ulna. And most of the orthopedic surgeons, they are thinking that the treating radius and ulna in any case is difficult. Not so difficult. You must be meticulous. You must be intelligent. And you have a good idea regarding the structures of the radius and ulna, muscles and bones. You can get very fantastic results. Even osteomyelitis, radius and ulna, and any kind of deformity and any trauma in the proximal and distal. Even then, Montegia Giliazi fracture we are also doing by Ilizarov technique. You can do in other ways also, but you can do any kind of surgery, including the trauma case, deformity case, by Ilizarov technique in radius and ulna. And at the same time, I've shown you some cases of the metacarpal bones. You can do that also. Very interesting also case is non-union of the, scaphoid bone. You can treat it. You can treat this scaphoid bone by Ilizarov also. Because I can show you a lot of things, but time is constrained. Not possible for show you everything. So thank you.
Thank you very much. Though it is very easy for you, sir, but it is very difficult for the young surgeon to do Ilizarov in case of forearm and hand. And I myself face very difficulties in case of forearm and hand. So I never tried that second time without the help of the seniors. Sir,
Yeah, of course.
What challenges, what type of complications do you face in case of your own operations, in case of forearm and hand? Would you please share with us?
Yes. Any surgery, you have got the complications. And as for example, if your radius and ulna, you must know how to place the forearm bones in this way. This is your ulna. If you go for this side, this is from coronal plane, you go to touch the ulna. Then from this side, this brachioradialis, you should have to know the interosseous nerve here. You can put your first wire or second wire through the radius, just prick the radius. You can palpate. There is not bulk of muscles here. You can palpate. You just prick your radius and then you can go through the ulna. This is the proximal part. If your non-union is here, you touch one radius. Just you should have to keep it in your mind. Here is your radial artery. Just you place your finger here. You just understand this is your radial nerve. Avoiding that, you can go through the simple wire. For radius and ulna, 1.5, or if patient is very bulky and heavy, you can go for 1.8. So direction I have shown you in different levels. One day you cannot learn everything. If you see the 3, 4, or 5 cases, then you will be able to understand how to pass the wires and how to fix the Ilizarov wires with the rings. And corticotomy is very also easy, not difficult because you can palpate. Not that this is the femur. The bulk of muscles is here, just like tibia. Only the structures, ulnar nerves and brachial artery, these are the vessels, and distal radial artery, and this is the interosseous nerve. Nothing else, only 4 or 5 things here. Then you can go for your treatment by Ilizarov technique in the forearm bones.
Thank you very much, sir, for your nice and magnificent presentation, and also tips and tricks for young surgeons regarding the forearm and hand. Our international faculty, Professor Novikov sir, is not with us as because of the network problem. Dear viewers, today is the topic is the forearm and hand, and I think we will discuss about the non-unions and the osteomyelitis in the coming program of our Orthopedic Solution Academy, and I hope you will get lots of new information regarding the treatment of osteomyelitis by Ilizarov, and definitely gap non-union and different type of non-union treatment by Ilizarov. Sir, would you please say a few words regarding the treatment of non-union and osteomyelitis by Ilizarov that you are going to discuss in our next program?
We'll go for case discussion. Now we'll talk. We'll show the cases. How do you suggest? I can put the different varieties of osteomyelitis. I will seek the opinion from the audience, or I can show this is the case what you'll treat. Then what we have done, we'll show you. Probably.
You will decide what will be the best for the young surgeon also.
For the young, those who are loving Ilizarovians. You see, Tanveer, I always invite all the young orthopedic surgeons. You see, you can cover everything by single technique. That is the main thing. By single technique, if you cover all these things, you can cover geriatric, pediatric, any kind of non-union in the adult. And why people are afraid of this Ilizarov? Why, you know, doctors? Because they don't have basic idea, basic principles. And now I'm happy that a lot of young orthopedic surgeons, they are very much interested in Ilizarov surgery, because a lot of things you cannot cover. You just think any congenital acquired deformity of children. That's why I tell always my pediatric orthopedic surgeons, you learn Ilizarov, then you can cover everything. Everything you will cover. Adult and children takes Ilizarov very easily. They are doing jumping and walking, everything with this Ilizarov apparatus rather than adult. That's why I always invite the young orthopedic surgeons, you try to learn Ilizarov. You can cover trauma, you can cover any kind of deformity by this technique. Monoaxial, 2 to 3 weeks, 3 to 4 weeks, you can cover everything. Then you can go for Biaxial? No. Ilizarov is multi-axial, and three-dimensional deformity you can treat this by Ilizarov technique. And for third world country, for my country, Ilizarov is the best option. Only if you learn it properly, you can get very good results. And that I'm facing in my life. And I'm doing all these cases that I told you before: peripheral vascular disease, diabetic foot, diabetic neuropathy, diabetic Charcot joint. All you can do: vascular disease, Barger's disease, thromboangitis, atherosclerosis. These are all best options by Ilizarov. So my message is, next time, next Saturday, Friday, Professor Novikov or I myself will discuss and will let you know. So we are going for osteomyelitis, very important, and non-union. These are the very common things. Now Novikov is here. Novikov, we are going to talk on osteomyelitis of non-union next sitting.
And I will help you. This is your topic or my topic?
Your topic. Which one you want to take, osteomyelitis or non-union? And both together.
No, what is better for you? Take osteomyelitis. I will take non-union.
Okay, I will take osteomyelitis. You take non-union. And tomorrow, next week, we'll talk, or what? Tanvi, tell.
I think, sir, individual presentation will be better.
Yeah. Next time we will together.
Together, no. You talk next time, non-union of the long bones.
Yeah, non-union long bones.
Long bones, okay? Tanvi, okay?
Yes, sir.
Yes. Next time, next Friday, I'll talk on osteomyelitis.
Thank you very much, sir. Thank you very much for being with us and
Thank
for
you.
being with Solution Academy. I'd like to thank our honorable academic expert from abroad, Professor Novikov sir, and definitely our very respected teacher, Professor Mofakarul Bari sir, for being with us and for sharing their knowledge with us. And salute to them because only for them we are here, and we can learn many more things from them. Dear viewers, today this is the end of our program, and I would like to thank Raj TV for helping us to do this sort of program, and definitely Renata Pharmaceuticals Limited for being with us. And I would like to thank Dr. Basudev for helping me all the time to arrange this type of academic program. And dear viewers, I'm Dr. Mahmoud Tanvir Ashraf saying bye-bye to you, and hope we'll see you in the next Friday with non-union Ilizarov. Till then, have a healthy life. Bye-bye.
You are watching Raj TV. Jago